Now let's move on to lower esophageal sphincter and motility conditions. The first one and the most high yield of these conditions is achalasia. Then we'll talk about scleroderma, esophageal dysmotility, and we'll finish it off with a motility problem, the esophageal spasm. So achalasia, what does that actually mean? So chalasia means relaxation of a body cavity. A means no in medical terms, like asymptomatic means no symptoms. So achalasia literally means no relaxation of a body cavity or opening. So they're referring specifically to the lower esophageal sphincter in this case. There's no relaxation of the lower esophageal sphincter, and that's what's going to cause all of our symptoms. So why does this happen? Well, what happens is that our lower esophageal sphincter can't relax because of damage to our myenteric plexus ganglion cells. So now we have to talk about the myenteric plexus really quickly. This is from our GI tract intro lecture when I referred to each of the layers and what they do. As you can see, the myenteric plexus has an important role in regulating sphincter tone in addition to peristaltic contractions. Those are the two things the myenteric plexus does: peristalsis and sphincter tone, okay? So if we look at the myenteric plexus again, you can see that it's just responsible for these two things. And if they're injured, you're going to have both a loss of peristalsis and abnormal tone. From our physiology section a little bit ago, I told you that the myenteric plexus regulates nitric oxide and VIP, and so that can be a problem that we can show you right here. Here's our lower esophageal sphincter, and normally nitric oxide or VIP can come in and relax the lower esophageal sphincter, and life's good. The problem is that this whole pathway is mediated by our myenteric plexus neurons. They're the ones who are secreting these compounds. So if you have a deficiency in these neurons, you're not going to get any of these compounds, and this lower esophageal sphincter is going to remain closed. And what that's going to do is it's going to cause a lot of backflow, like we're going to see. There's two ways this can happen. So how do your myenteric nerve ganglion cells get damaged? The first way is primary achalasia, which means we have no idea, basically. Your cells are dying, but it's all idiopathic, which just means we don't know the cause. Kind of like primary hypertension, we don't know why somebody's hypertensive, whereas secondary hypertension, we know the cause. And so same thing, in secondary achalasia, we know the cause. And that cause is either due to malignancy. You can have a tumor that's invading into those tissues and destroying the myenteric ganglion cells, or something that you've probably learned about on your step 1 studies is Chagas disease or Trypanosoma cruzi. That can also cause, you can get mega esophagus, mega colon, and that's all because the myenteric plexus is getting damaged and you're getting, absence of peristalsis, so food's just sitting in your stomach and in your GI tract and dilating, and that's a form of secondary achalasia in this instance. So this has a very unique presentation, I should say. It's going to be dysphagia of both solids and liquids. Remember that with the cancers we talked about so far, this squamous cell carcinoma, that started with dysphagia of solids and then progressed to liquids. And this one, because your lower esophageal sphincter is closed, it doesn't matter if it's a solid or a liquid. You cannot tolerate either of those. So that's really, really important. They like to show you this barium swallow, where it's going to show you a bird beak sign. And remember, we don't use barium in Boerhaave syndrome because it can cause mediastinitis. I just want you to remember that for the future. So this bird beak sign. So as you can see, maybe I should explain what a barium swallow is first. So what you do is you're going to consume barium, and then you can have x-rays taken of your esophagus so that we can see exactly what's going on, how you're able to swallow the barium, and if it goes to your stomach. And in achalasia, all that barium can't get through that really tight esophageal sphincter, and you're going to get the bird beak sign. So you can see how it's all accumulating right before the LES. And you get this bird beak sign, which you can see at the very bottom right there. Now you can also diagnose this through esophageal manometry, and it's going to show up as high lower esophageal sphincter pressure or tone and absent peristalsis. And so let's see what this looks like. So esophageal manometry, how that works is that you extend a tube from the mouth to the stomach, and then what you can do is you have them swallow, and you can record their muscular contractions at each level of the esophagus. So in achalasia, it's going to be typified by high lower esophageal sphincter pressure, and that makes sense. It can't relax because there's no myenteric plexus neurons anymore to help it relax. So if we look here, this is kind of talking about the LES tone. I drew in the dashed line is what would be considered a normal tone, and in achalasia, you can see the tone is increased. I just also want to point out that you can get absent peristalsis because we also need our myenteric plexus neurons to help out with peristalsis. So in a normal situation, you'll have this part of the esophagus contract and then this part, and so you can have food moving down correctly as they contract in unison. But the problem with achalasia is you have this random or absent peristalsis. So not only does your lower esophageal sphincter not work, you don't have any coordinated peristalsis in the first place. And so the complications of this is that if you have a backup of food, that can push against your esophagus and cause chronic inflammation and irritation. And that can also cause squamous cell carcinoma. So if they're going to test you on achalasia, you always have to think about other differentials, especially with the lower esophageal sphincter. And the most common differential that you're going to encounter is sclerodermal esophageal dysmotility. And so what this does, so first off, scleroderma is an autoimmune condition typified by fibrosis of all your skin, connective tissues, and organs. And how this works is that the lower esophageal sphincter gets replaced by fibrotic tissue, and so it doesn't work as well, and it actually causes decreased tone. And so my mnemonic for this is that when I think of scleroderma, I think of scleroderma because it's very low. The tone especially is going to be low because it's replaced by this fibrotic tissue that doesn't work as nicely. So if we go here, if we look at our tone again and we go through what's normal, we have scleroderma or scleroderma with a decreased tone here. And just something to remember with scleroderma, they do like to test this crest syndrome. So if you have somebody who's having dysphagia, usually like in a young woman, just keep a lookout for some of these other phenomena, calcinosis, Raynaud's phenomenon, sclerodactyly, and then telangiectasias. They probably won't give you these specific phrasings. They'll tell you about the hands changing color for Raynaud's. They'll kind of give you a little bit, they'll make you work for it a little bit. But if you see somebody, especially a young woman with dysphagia, make sure to pay attention to some of these other associated symptoms, because then it'll make it more likely that they're talking about scleroderma versus achalasia. And the last one I'm going to talk about, not so much a lower esophageal sphincter problem, but just a general motility problem, is esophageal spasm. And so the pathogenesis of this is that you have uncoordinated contractions of the esophagus. And there's nothing wrong with your lower esophageal sphincter, but you just have these weird contractions going on in your esophagus that prevents food from going down in a coordinated pattern. And so how do you diagnose this? The easiest way is through a barium swallow that'll show a corkscrew esophagus. And so you can see right here on the right, you have a corkscrew esophagus that's very twisty and curvy. And on esophageal manometry, you're going to get normal LES sphincter tone, but very, very weird peristalsis. So if this is our normal tone right here at the bottom right, you can see in diffuse esophageal spasm, it's actually pretty normal. It comes back up to baseline like it should. But the peristaltic contractions are very abnormal. They don't have any rhyme or reason. They're not methodical in any way. And how do you treat this? You actually treat this with nitrates and calcium channel blockers to kind of calm those spasms down. Thanks for watching. I hope you enjoyed the video. Please like, comment, and subscribe for more content.